So good morning, everyone. My name is Dr. Sanjay Rampal. I'm a professor of epidemiology and public health medicine, and I'm also the Deputy Dean of Research for the Faculty of Medicine. Today, we are very lucky to have with us Dr. Vivek Jason, who is a gazetting public health physician. His fields of interest lie at the intersection between data analytics, epidemiology, and infectious diseases. A medical doctor by profession, he recently received his doctorate in his Doctor of Public Health from the University Malaya under the supervision of Prof. Ng Chu Wan and myself. His thesis journey has allowed him to delve into various projects that resonate with his passion for data science and infectious diseases. This centered around the epidemiology of COVID-19. He has worked on elucidating the utility of NPIs, non-pharmaceutical interventions, and evaluating the comparative effects of disease burden and transmission on health systems. His work not only illuminates our understanding of the pandemic, but guides policy towards more effective and, importantly, humane interventions. More than just being a physician, Vivek is an ardent student of numerical narratives, deeply fascinated by the stories that numbers can tell. His wide-ranging expertise allows him to synthesize knowledge from these diverse domains. Jason is a deep believer in the synergy between data and empathy, and he takes a balanced approach to his work. He navigates the intricacies of his field with a hint of humor, as you will see, understanding the pursuit of a healthier future in both a serious and humbling task. His vision revolves around using data-driven insights to inform empathetic healthcare decisions, demonstrating his passion for a healthier future that's just not only data-informed, but also people-centric. Get ready for an engaging breakfast talk that serves a rich, insightful dish about the spread and impact of COVID-19. This comprehensive discussion will provide an in-depth look into the epidemiology of the virus, not only within Malaysia's borders, but across the globe. Off to you, Dr. Vivek Jason.
Good morning, Prof. Sanjay. Thank you for the kind introduction. And I'm usually not very comfortable with such kind words being said about myself. Are my slides?
Yes,
okay.
It is.
So, the title of my presentation for today, we'll be talking for the next 30 minutes, is Epidemiological Espresso, Waking Up to Data-Driven COVID-19 Control. As you can see, the title is part me trying to be clever and also part me trying to really encapsulate what we have been doing over the last 3 years. I think everybody is no stranger to the last 3 years, and COVID-19 has been an interesting journey in public health and in global health. And over the next 30 minutes or so, we'll have an in-depth look into the epidemiology of the virus, not just within the borders of Malaysia, but also across the globe. So this talk will explore some of the incidents of COVID-19 in Malaysia. We're looking at cases, fatalities, vaccination programs, NPIs, as Prof. Sanjay mentioned, non-pharmaceutical interventions. And we'll follow that up with presenting some of the work that we've been doing, especially with regards to the Delta wave that was particularly deadly in Malaysia. We then shift a little bit to global perspective, looking at the unique patterns and trends across the world and trying to really understand the diverse factors that influenced the spread of disease across the world. Finally, we share some of the open source data solutions that we designed really to help professionals and public keep tabs on the pandemic's progression and to prime us for future pandemics and what we can really do in terms of scaling up solutions for optimizing public health interventions. So despite it being a sort of a serious subject matter, this talk is, and we try to make it as lightheaded as possible. But we do hope that it will provide you with some information that you can take along in the journey that we take down the global health route. So I won't waste any more time, jump straight into it. We're all very familiar with maps like these. Blood red in just about 3 years, COVID-19 has been reported in every country in the world with close to 700 million reported cases and 6 million deaths, right? Transmission of COVID-19 is unprecedented, right? It's the global health crisis of the century, and you can visually appreciate its global spread. You don't have to be an epidemiologist for that, right? The red tells you that. And all over the world, its propagation has resulted in battered economies and really overwhelmed health systems. The one real silver lining that we can find within global health in this pandemic is the transformative potential of empiricism and data, right? The provision of near real-time spatial and temporal epidemiological intelligence that could be translated into inputs for the optimization of public health action. And that may already provide you with sort of the flavor of what we're going to be talking about in the next 30 minutes or so, right? So I'll just give you a short, brief outline of what we're going to do in the next 30 minutes. We'll start off first by trying to decode the Malaysian data and derive some interesting lessons there. We then zoom out to a global perspective and explore how transmission mortalities, NPIs, and I'll routinely use the word NPIs to suggest non-pharmaceutical interventions, and vaccinations cluster across the globe, right? We then discuss the open source solution, as I mentioned, and we finally try to tie everything together and attempt to chart a course into a foggy future. So let's first look at the Malaysian data and some lessons that we can learn, right? The first bit of data that we'll try to bite into is the data on testing, transmission, and NPIs, right? So what you see before you is just several colorful looking plots, right? On the top, what you see is an epidemiological curve of case counts. And this is between January 2020 and June 2023, right? So it's updated up to about a week ago. And below it, in purple and yellow shades, we see the test positivity ratio, which is basically the amount of the amount of cases per the amount of tests that are being done, followed by the dominance of variants, right? So on the y-axis, you see all the different variants that came in, the ancestral, moving on to Delta, and so on and so forth. And finally, right at the very bottom, in traffic light colors, we see the NPIs, the non-pharmaceutical interventions. And you can see quickly, just from the order, we see that the first 6 or 7 interventions are public health interventions, things like facial coverings, contact tracing, testing, and that is followed by more restrictive interventions, the MCOs, public transport. Deeper red colors signify more intense policies, and of course, green signifies the converse. Overall, from this slide, we can tell that across time, we have quadrimodal peaks between January 2020 and June 2022. But proceeding that, it's not so clear. We have small peaks and almost a consistent stream of transmission. The first wave, as we all know, occurred between March and April 2020. Test positivity was very low at this point. And we see that the number of cases peaked at about slightly more than 200. So it wasn't really a very intense level of transmission, and effective interruption was achieved via really heavy use of NPIs, right? This was followed by what is now known as the Sabah election wave, right? So outbreaks in closed institutionalized populations in Sabah and the state elections, and also short relaxations of several NPIs. You can see the box in red right at the bottom in late September 2020 suggested a short pulse reduction of the NPI intensity. And this was sort of a catalyst for significant community spillover, and of course led to large increases in community transmission. This state election led to a steady state of increased transmission across late 2020, right? And when the emergence of Alpha and Beta in early 2021, followed by Delta in April 2021, as the transparent red box will show you, ensured that transmission was cyclical, right? It was never truly unbroken. And that also meant that the amount of circulation within the community was high. There was an increase in intensity of the NPI called the FMCO, we may remember in June 2021. And it appeared to stifle transmission slightly, but the rapid rise of Delta in this period and the easing of several NPI, which you can also see highlighted in the red box below that, led to large increases of transmission. And it is what we now recognize as the Delta wave. This is then followed by late 2020 with vaccinations coming in, easing of a lot of the intense restrictions with the National Recovery Plan 1, 2, 3, and 4. We see the emergence of Omicron BA1, slightly less dark red. BA1 is in January, and then BA2 in about February. There's a little bit of co-circulation, and this led to a significant increase in transmission. We see that this wave is a lot more, the slope of the curve is a lot more intense, right? Increases really quickly, hits very high peaks, and then drops. And this can also be related very much to, of course, the removal of NPIs. However, we will discuss a little bit of this in the when we look at mortalities. And finally, we zoom into where we are currently and where the pandemic has progressed into an endemic state, as we have so called it currently. We do see some waves, especially in late 2023, early 2020, late 2022, early 2023. And these are mostly driven by, these were driven by the BA4, BA5 wave, and then there was more recently an XBB wave. But the waves themselves are of smaller magnitude, and there's a steady, persistent baseline of endemicity. Right? One caveat to this is that if we look at the TPR, the test positivity ratios, the red boxes show you that, never across the pandemic has our test positivity ratio been so high. And what that simply means is the degree of underestimation that is possibly happening in this current period is probably extremely high. So to tie in what we found from just those findings, right? Very high intensity non-pharmaceutical interventions were used very effectively in 2020, and they reduced transmission early on. They were very effective in 2020, but we see that there was diminishing returns in 2021. Long-term movement restrictions have not resulted in containment of disease, and the rise of highly transmissible variants, pandemic fatigue, and long-term immunity, right, may have likely resulted in the diminishing returns of these NPI. Continuing to look at numbers in Malaysia, we'll look at the mortality rates, case fatality rates, healthcare capacity, and some of the vaccination numbers across the country. This is a very simple plot, a line chart across time, same time period, January 2020 all the way up to June 2023. Over this time period, we see three plots, stacked plots, right? At the top, the pink visualizes the case fatality rate, which is just the ratio of COVID-19 deaths cases over time. In the blue, the mortality rate, followed by COVID-19 associated hospital admission, ICU, ventilation for COVID-19, in red, orange, and yellow, right below it. And the lowest chart visualizes the first, second, and booster doses of the vaccine across time, right? And immediately, the thing that captures your attention is the flattening of the CFR, mortality rate, and healthcare capacities beyond September 2021, right around the time that we ramped up the second dose of vaccinations. And this was further pushed down after the booster doses, right? So this is an interesting and striking observation. We can also see that that there is a disproportionately deadly Delta wave, right? So in September-ish, June, July, September of 2021, we see that the peak of mortalities is also the highest. If you remember the transmission that we saw earlier, lots of peaks and troughs, but this mortality rates, we don't see those peaks and troughs as clearly, but delta is very, very clear. Across time, we see that there's about 37,000 people have died to date over 3 years. 89% are Malaysian and 11% non-Malaysian. One very interesting fact that we find, if we dig a little deeper into the data, is that we find a discrepancy of nearly 14 years in the average age of death from COVID-19. And while this does not confirm anything, it remains a concerning signal within the data. Adjusted analysis suggests that the odds of BID is nearly 80% lower in Malaysians compared to non-Malaysians, further confirming a potential signal of concern within the data. So there are two things that we can talk about here, two narratives. Number one is that the vaccines have been extremely effective, but the lower virulence of the current strains, Omicron, right, also possibly had an attenuating effect, right? And that's why we see CFR and mortality rates dropping. And number two, there's a great deal of spatio-temporal heterogeneity in deaths and incidents, right? So it's higher and more populous in the urban central regions of Peninsular Malaysia. And more concerning is that it's differentially distributed across the population, with mortalities being reported in higher per capita in marginalized populations and of course institutionalized populations. We also delved a little deeper into the Delta wave. As I mentioned, the Delta wave was fairly deadly, and we tried to gain some intuition into how bad the wave was. We asked two questions, right? Number one, what was the true burden of cases? Number two, what was the true burden of deaths? So the first thing we did, we observed a total of 2.3 million cases between March 2020 and December 2021. The first question that we asked of the data was, what was the true burden of transmission across this period? So we designed and implemented a multiplicative modeling approach, right? Using death rate, infection fatality rates to estimate what this number would be. And we found that a total of 9.96 million cases were estimated based on this model, right? This corresponds to a population prevalence of 32.8%. What this says really is that we underestimated cases by a factor of 4. The largest increases was found to be in the younger age groups, with decreases in overall proportions in individual age above 51. The second question that we asked was on the true burden of mortalities in Malaysia. And to understand this better, again, we used the modeling approach using all-cause mortalities across Malaysia in estimating the expected number of deaths in 2020 and 2021, same time period up to September 2021, and compared that to the observed number of deaths that we saw. So what we immediately see in 2021 is that excess was largely negative. When I say excess was largely negative, I mean the observed number of deaths was far lower than the expected number of deaths, up to 5.5 to 23.7% lower. But that was completely reversed in 2021, with large increases in excess mortalities during the Delta wave. And this increase corresponded to about 13 to 24% increase across this period. When we stratify by age, we see where these excesses were occurring. In individuals aged 14 and below, the younger age groups, we see no excess mortalities, but the proportion of excess deaths that were occurring in the older age groups were much higher. Excess deaths attributable was between 74 and 90% in individuals aged 60 and above, suggesting that these individuals, the older age groups, were not just affected by COVID, but they were potentially affected by the Delta wave paralyzing the health system. So other causes of death as well. Again, this is not a confirmation, but a signal. Finally, we also just wanted to share a point of interest that we found, right, is when we look at the RTA deaths, road traffic accident deaths, we find that road traffic accident deaths decreased by 12 to 80% in 2020. And this was likely attributable to the fact that large-scale MPIs, right, were put in place, or MCOs, meant that fewer people were on the roads. And so if there was any benefit, this was probably one of it, if it can be considered a benefit, right? So what were the lessons or the narratives that we can take away from this? The differentials of incidence vary by time and age strata, but the underestimation factor was about 4.3, right? Now, that may seem like a lot, but it's actually comparable to a lot of other countries, including developed countries like the US and the UK, right? Now, differences of age-specific prevalence above 65 is observed with other countries, right? And estimates here may differ to countries like the USA. And this is likely due to differences in underlying population structure, right? Younger age groups also consistently report comparatively lower prevalences and the highest degree of underestimation. And we think this is likely due to the predominantly asymptomatic transmission, lower severity, and implementation of long-term school closures in this age group, right? We also see that preferential testing of older individuals probably played an important role. And so we have preferential ascertainment in these age groups. Now, there's also trends of excess mortalities that we talked about earlier, and it largely reflects the trends of COVID-19 transmission, largely negative in 2020, and large increases in 2021 as the variants emerged. Younger age groups consistently report no increase, while older age groups report the converse. Trends of excess mortalities have reflected trends of COVID-19 transmission, and we see that also of interest is that less accidental deaths and less respiratory infections probably also reduce the amount of deaths in younger age groups. Thirdly, we will look at a global perspective. We try to zoom out. We used an interesting methodology for this one. We used time series clustering approach. We used an algorithm to look at time trends across 2020 all the way to 2023 and stratify these into clusters. Now, looking at 200 odd countries one by one is difficult, right? So we wanted to reduce the dimensions that were available to us. And by doing that, we could then regress country characteristics on these clusters and be able to describe these clusters in certain ways, right? What these country characteristics, what were the country characteristics that we used to describe these clusters? They included things like GDP per capita, population density, and also things that looked at healthcare capacity like diabetes prevalence, the proportion of aged individuals above 65, things like that, right? And so this looks like a very noisy slide with lots of things going on, but what it basically tells you is that we clustered incidents across time, across 3 years, and we find that across the 3 years, the reason we didn't do it in one time period is that the 3 years are distinctly different and testing rates are distinctly different over these 3 periods. While of course, ideally, we would like to drill down a little deeper into temporal space, but we decided on 3 years as it would give us a nice resolution, a temporal resolution, right, to investigate. And what you are seeing are 3 colors, traffic light signals again, and we clustered the incidence of cases across time into 3 clusters. And that basically means there are countries in a high incidence cluster, moderate incidence cluster, and low incidence cluster. And it made it inescapably clear that there's huge heterogeneity in disease spread across our global village, right? We found the partitioning of incidence, as I mentioned, in 3 distinct clusters. And countries in cluster 3, high incidence clusters, were consistently parts of Europe, America, and South Asia, right? A lot of the developing world was in this cluster. It painted a worrying tableau of transmission, right? Exhibiting highest incidence, as I mentioned, in almost all the same countries. And the only countries that consistently recorded were observed to be in cluster 1, right? Low incidence clusters were mostly small island states. None of the larger countries were in these were clustered here. So when we used a regression analysis, you can think of this like as a computational sieve, right? We have clusters and then we try to associate features to these clusters. We find that multiple features have some sort of association, but we just wanted to focus on 3 features, right? The longer a country's life expectancy at birth, the higher the odds that it fell into moderate incidence clusters, right? And this may not come totally as a surprise. This was consistent in 2020 and 2022. Secondly, we find that for population growth, the converse is true, right? If you have higher population growth, you are more likely to be in low incidence clusters. And finally, we find that healthcare infrastructure in this case, more hospital beds, surprisingly increased countries' odds of being clustered into the moderate incidence cluster. In other words, very similar to what population growth is telling us, right? If you have fewer hospital beds, you're likely to be in low incidence clusters. And we'll talk about the narratives a bit later, but we also clustered the mortalities, and we find that there are 4 distinct clusters in this exercise. Clusters 2 and 4 are trimodal peaks, right? 3 peaks, while clusters 1 and 3 are bimodal. We have 2 major peaks, right? And while there are the peaks between the time periods and space, we do observe, again, a great deal of asynchronicity across time and region. Right? Intriguingly, much of the Western world had much higher rates in 2020. But in 2021, that shifted to other territories. And you can see that signal, right? If you look at Europe, it's red in 2020, and 2021 it becomes the area around Europe becomes slightly more green. And then in 2022, however, the burden of deaths shifts back to these parts of Europe. Again, using the regression analysis that I mentioned earlier, we find that life expectancy emerges as a significant predictor of cluster membership across all years. It suggests that overall health, as indicated by life expectancy, is highly associated with that, right? So higher life expectancy is associated with higher mortality clusters. Likewise, diabetes prevalence is also associated with higher mortality clusters. And counterintuitively, higher hospital beds predict for increased mortality rates. We also looked at vaccination rates. And if we look at vaccination rates, these were clustered into 4 clusters. There's a stark variation in average vaccination rates across these clusters over time. 2021, cluster 1 had the highest vaccination rate, 18 per 10,000 population. By 2022, vaccination rates generally decreased, with the highest rates found in cluster 2, 3.4 per 10,000 population. You can already see there's a stark difference in uptake here, right? Notably, of course, the distribution of clusters appears to be geographically skewed. For instance, countries in cluster 4 predominantly include parts of Africa in 2021 and 2022, which definitely has implications for the global vaccination strategy plan. Right? So again, with the regression analysis, we find that several country features were associated with cluster membership based on vaccination rate. Significantly higher life expectancy, again, is associated with lower odds of membership in clusters 2 and 3 across all years, converse to what we saw earlier. And a higher score on the Global Health Security Index was associated with decreased odds of cluster 3 membership. And in this case, cluster 3 and cluster 4 membership means lower vaccination rates, right? And this was rather intriguing, right? In 2022, we find that an increase in primary completion rates, right? That means education rates, increased the odds of cluster 4 membership. Finally, we looked at the stringency index, or the NPIs, apologies, where life expectancy at birth emerges as a significant predictor of cluster membership based on the stringency index across all study periods. A year increase in life expectancy consistently corresponded with a decrease in the odds of belonging to cluster 2 and 3, right? And for the period of 2020 to 2022, an improvement in the Global Health Security Index score was associated with decreased likelihood of cluster 3 membership. Now, that's a lot to take in, I'm sure, but we're going to try and distill what those findings mean in the global health context. Number one, spatiotemporal heterogeneity is a definite characteristic that we observe across time. The first wave up to July 2020 was relatively small. The use of strong measures was relatively consistent across many countries worldwide. The emergence of variants in late 2020 and reduction in the effectiveness of NPI led to the exponential of transmission globally, right? We see that happening globally, the rates and magnitudes of transmission differ largely between the countries, right? So countries in lower incidence and mortality clusters, we find that these are small number of countries that can say they did well. They mostly are small and island states, as I mentioned earlier. They leveraged increasing efficiency of public health systems and also adaptability in successfully interrupting, preventing re-entry, and deterring the reestablishment of transmission. They also had good vaccination rates. What was definitely clear from the analysis when we cross-synthesize between the analysis is that vaccines have been a game changer, right? So mortalities were clustered heavily prior to April 2021 in Europe. Rapid uptake of vaccines see that dissipation of that effect. And differentials in uptake have led to low mortalities now centering in parts of South America, Africa, and Asia. Right? Oh, apologies. Now, one very interesting fact is that we see a lot of the reversal of mortalities and vaccination rates in 2022. And we don't know why this signal is being shown, but we do think that maybe we speculate that this could be due to hesitancy and the role of disinformation and the vaccine wars that are going on in the West, right? Another signal of concern is the global inequity that we see from vaccines to surveillance, right? And what do I mean by inequity of surveillance, right? Consistently, you'll see that in incidence and mortalities, you find that higher income countries have higher number of cases, and that doesn't always make sense. But this could be down to the underlying underdeveloped surveillance and its eventual effect on key comparative metrics, right? So if you have a surveillance system that isn't as developed, you're less likely to pick up a large amount of cases. Now, again, this is by no way confirmed, but the signals do seem to suggest these. And finally, we explore the use of open source low-cost solutions and how we can try and transform the estimation and implementation of epidemiologic intelligence. And this was carried out locally in right? So this is what we did, right? This may seem like a rather boring, but this was the architecture that we developed in-house. And this is where we channel the data, right? So we created a GitHub where we mined data initially in 2020 and 2021 and later ported over to the MOH data sources once they became publicly available, right? And we put it up on our GitHub, and we use this as a sort of data ingestion, a database, and we pushed it into a dashboard, right? So this is just a short video showing you the dashboard that we developed. I'm not sure if you can see what's happening here, right? So what we did was we created this dashboard that looked at a lot of different indicators, things like transmission, as you can see here, incidence rate. We estimated the reproductive number, broke down cases by proportion, looking at different epidemiologic intelligence parameters, things like mortalities, mortality rate, breakdown of deaths by brought-in deaths, daily deaths. Also, we looked at the vaccination rates, BID rates. Sorry, I already mentioned the BID rates. The testing rates, which was particularly important in 2020 and 2021. The variance of concern, and this data was channeled from the GIS8 data, the GIS8 hub. We looked at vaccination rates across time, case fatality rates and vaccination rates, how these two sort of coincide, healthcare capacities across time. And of course, this is particularly important in the endemic period to see if we require surge capacity in terms of transmission, and mobility, of course, which was important in the early days, especially as we implemented NPIs, right? So we developed a framework of data crawling, data collection, data analysis, where we estimated different parameters of epidemiologic intelligence. And we then pushed it to a dashboard that could be consumed easily by, number one, the public, and number two, of course, the professionals, right? Now, the reason we did this was there was a positive collation and translation of data and epidemiologic intelligence early in the space of epidemiology in Malaysia. And so
Wait, if we can end this in a minute.
Okay, sure. almost done, right? And so the low cost, open source, rapidly scalable and completely reproducible solution was carried out for an epidemiology appointment. And finally, I'm ending, just my last 3 slides. Finally, we tie everything in with some thoughts on the future, right? So the pandemic has and continues to evolve. High transmission and variants initially suggested periodicity of between 1 to 2 waves per year. But we see that constraints of NPI removal has changed things, right? Thomas Pueyo wrote a captivating article early in the pandemic, right? It's called Hammer and the Dance, and you must read it, where the hammer is the fist that restricts transmission and the dance is ensuring measures after it to manage transmission. We must learn that too many hammer strikes and people suffer, effectiveness is reduced. So we need to learn to better time these hammers and then do the dance a lot better. Number 2 is the story of the cannery in the coal mine. If you remember, coal miners used to send canneries into coal mines, right? Basically, if the canneries died, that basically meant that they were poisoned by carbon monoxide, and that was an analogy for the surveillance system, right? Restrictive measures, bias time. Nonetheless, we need to really recalibrate our cannery in the coal mine, right? We need to think of how we can increase the sensitivity of our surveillance system and really prevent spillovers. And finally, we need to prepare ourselves for the future. This pandemic has given us some really important thinking points. Number 1 is the amount of research that is needed for equity, social protection. NPIs have been, apologies, I think I just ended my slideshow. NPIs, I think many people use it as a red herring to say that a lot of economy suffered, but it also just unearthed a lot of the social determinants that underlie our community. So yeah, COVID-19, I think, has been a dress rehearsal for any future potential pandemics. We need to take lessons away and develop a comprehensive framework for action. I end with this pre-pandemic thought, right? This Time magazine cover in May 2017 carried this headline: "We weren't prepared for COVID-19. We did okay, but will we be ready for the next pandemic?" Thank you.
Thank you very much, Dr. Vivek, Jason, for that very interesting presentation. Now, due to time, we will continue with the next presentation, but some of you have already written out your questions in the Q&A. And for the rest, if you have your questions, please write it out in the Q&A or chat, and Dr. Vivek will get back to you using the chat. So thank you all for your attention. And now we will move on to the second presentation. So Vivek, stay on and you can answer questions using the chat mode. Off to you.
Okay.
Thank you.